Once again, just for those that missed the first one, you missed the first one. My name's Ken. I'm one of the nurses down in the cath lab, but I am also our PICC team, and that's what they've asked me to come here and talk to you guys today about. And so I guess we'll just start at the beginning. What is a PICC line and what is a midline? Because there's a little bit of confusion, and on the outside they look exactly the same. They're even placed the same, but on the inside they're completely different. And so let's just kind of start there at the beginning. PICC. It's spelled PICC, and stands for peripherally inserted central catheter, so it really is a central line. The midlines are a little bit different. They actually stop at the shoulder. When I was a kid, baby nurse, whatever you want to call it, I always used to think, they kind of went to the midline, right? They just didn't go all the way to the chest, they kind of stopped at the middle, but they actually stop at the shoulder. They stop before they get to any central vein, and the subclavian, which is just past the shoulder, is considered a central vein, and so that would be a central line if it went to there. But there's been some issues here in the hospital over the last couple of months. We'll talk about the CLABSI and the concern for those kinds of things. And we're such a small hospital here that even a single CLABSI is a big deal for them as far as numbers go. And so it's kind of important that we make sure that we kind of avoid those things. So central lines, PICC lines, like I said, peripherally inserted, which means it goes in the vein in the arm. The nurses can do them. Nurses who are trained or volunteer to be trained, like I did. I didn't really volunteer. I was shanghaied.
You were voluntold.
I was voluntold. Can place them. My training as far as placing goes was I paid my own $50 to do an online class, and then I got sent to Harris Southwest, and I got to spend a week with the PICC team there. I was a little bit on the job training, and then I was let loose, and it was interesting the first couple of months to be here by myself and try to figure it all out. But slowly but surely, I've gotten to a point where I feel I'm pretty confident. When I walk into a room, I can almost always get a PICC line and midline without too much trouble. But long story short, that's not what you guys are here for. So finished with the anecdotes and the fun stories, and let's get to talking about the meat of the program today, which is going to be PICC lines. So PICC lines are central lines. So they're to be treated like a central line. The dressing changes need to be done once a week. The little green caps need to make sure that you stay on them, even more so than peripheral lines. They're very, very important to make sure that you treat these with kit gloves and sometimes even sterile gloves. I guess the best way to start this would be what kind of questions do you guys have? And I'll see if I can't kind of tailor this to those questions.
What's the usual length of time we can squeeze out of a PICC line?
Okay, length of time, what else?
You said dressings are once a week?
Yeah, usually once a week.
Is it a certain day, or does it depend on when they're placed?
Okay, so those are the very good questions. So as far as length of times, PICC lines and midlines both have about, PICC lines have about a 6 to 8 week lifespan. Midlines have about a 2 to 6 week lifespan. Midlines, though, are a little bit different in the fact that they oftentimes, because they're in a slower moving or slower flowing vein, they will not necessarily clot off, but they will get fibrin sheaths that will prevent them from being able to, draw blood on them. And so a lot of times nurses will think, well, if I can't draw blood on them, then they're not good anymore. And we can talk about that here in just a little bit, but those are the usual time lengths. So PICC lines, 6 to 8 weeks. They can be in for quite some time, sometimes even longer than that, as long as they're taken well care of. So if you have somebody that comes in that's 26 weeks or something along those lines, that they want to get all the way up to 36 weeks or whatever before they deliver, that's a little longer than 8 weeks. So in those kinds of cases, as long as they're taken care of, there's no signs or symptoms of infection, then they can stay in a little bit longer if necessary. Ideally, though, they come out as soon as you no longer need them. Midlines, like I said, so let's step back to the PICC lines. PICC lines live all the way in the center of the chest, and so there's a lot of blood flow that's there in the center of the chest. You have 1.5 liters a minute that's flowing through the superior vena cava, the cavo-lateral junction, which is where the tip of the catheter lives. And don't worry, there's not a test.
Good.
So caval atrial junction, or the superior vena cava, the caval atrial junction, is where all the blood flow kind of comes into the heart from both the top and the bottom of the body, right? So about 1.5 liters of blood that flows through there. Midlines, and I'm going to jump back and forth between the two of them pretty frequently here, and I apologize for that if that gets confusing. And you guys are more than welcome to call me on Vocera, by the way. You can call me at Ken Day, or you can call me Ken in Cath Lab. Either way, you can get a hold of me. But anyway, midlines, because they stop at the shoulder, that the veins that we put those in usually have about 15 to 25 cc's per minute. And so the blood flow is significantly less there, which means that the tip of the catheter is going to have which is where any clot is going to start to form at the tip of the catheter, because that's where the catheter changes shape. Does that make sense? It goes from being this nice smooth tube to all of a sudden ending. And anytime that you have a change in shape like that, that's where fluid kind of gets stirred up a little bit. And where fluid is stirred up, or where it sludges, that's where it's going to clot. So the tips of the catheters is where usually clots start to form, and usually it's not necessarily a clot like a blood clot like you think of when you have bleeding or when you pull out a clot from wherever. It's usually what's called a fibrin sheath, and fibrin is a protein that's in the blood that is kind of the basis for a clot to form around. It's what platelets stick to. It's what activates the clotting cascade. But it's that fibrous base that a clot forms, and that's what forms around the catheter itself. And in midlines, much more so than in PICC lines because of the lack of blood flow, midlines have those happen very frequently. Usually it only takes a week or so for that to happen. When a fibrin sheath forms, when you try to pull back on that catheter, that fibrin sheath that's wrapped around the catheter gets pulled back in, and that's what keeps the catheter from being able to pull to draw back. Does that make sense?
Mm-hmm.
But you can oftentimes push the fluid through without much problem at all. It's maybe a little bit of problem, but most of the time not much problem. But as soon as you try to pull back, it sucks that little sock that's wrapped around that catheter and pulls it back into it and keeps it from pulling any blood back. And if you pull hard enough, you're going to pull that fibrin sheath into the catheter, and once that's there, then it's going to keep building up into the side of the catheter, and then it's going to completely clot off. So that's why midlines oftentimes don't last near as long as PICC lines. So if it's truly going to be a long-term thing that's going to be multiple weeks, then PICC lines are usually the best answer, because they are where the tip of the catheter lives for the PICC line. There's much more blood flow. That fibrin sheath doesn't build up near as fast. Although it still can. We had a little lady that was up here 6 or 8 months ago.
She was mine, yeah.
That had a PICC line that eventually stopped drawing. It's still flushed. You could still give medicines to it, but it eventually stopped drawing. And those are usually the reasons for that, is that fibrin sheath. And here's the downside. TPA, I'm not going to do a single thing about a fibrin sheath, because if you get the fibrin into the catheter and it totally clots off that catheter, you're not going to be able to instill enough TPA to get in there to do anything with it. And if the fibrin sheath is still on the outside and not inside, then when you push the TPA, it's just going to push out and go to the rest of the body, and it's not going to stay there. So it really is not going to be able to live where that fibrin is at to be able to break that down. TPA is what breaks down the fibrin, right? I mean, that tissue plasminogen activase is what breaks down that fibrous clot. But because of the way the mechanics work, it just doesn't do a very good job with that. So that talks a little bit to the life of the catheters. You asked about dressing changes. So dressing changes, and I have to apologize, I'm not part of the committees that do that kind of stuff here on the floors and in the hospital, even though you would think I would be, but I'm not. Typically, dressing changes are done once a week. In the old days, and when I say the old days, I mean probably just as recent as 6 months ago, they used to be done every Tuesday. In fact, when I place midlines and PICC lines, I put dressing change due on Tuesday because that's still my habit. That used to be the National Central Line Dressing Change Day. They had staff that would come in just on Tuesdays. They'd come to the big hospitals and they'd go through the whole hospital and change everything on Tuesdays. Nowadays, I think though it's more of changing just once a week from the date that it's placed. I heard somebody up in PCU tell me that they change them the day after it's placed, so that if it's placed on Monday, they change it on Tuesday regardless, and then they retime it from Tuesday on. So if it's placed on Friday, they change it on Saturday, and then they time it every Saturday from that point forward. I'm not sure the reason for that, and I wish I'd have thought to ask somebody upstairs. I apologize, but I will get back to you guys on that and find out what their reasoning for changing it the day after. But that's dressing change. Dressing changes are done sterilely, so sterile gloves, sterile pack. I don't know if you guys want me to kind of walk through one of these, or
I think it's all listed there on the outside of the, isn't it, on that little red, but anyway, it's
so
just
when
gloves and such.
you do a sterile dressing change, it's just like any other sterile dressing change. You want to do it aseptically as much as possible. The kits, I believe, come with chlorhexidine prep that's in there that you can clean the site with if it's fouled with blood. You'll do it with sterile gloves, so just whatever size sterile gloves you have. Take the dressing off with non-sterile gloves, put your sterile gloves on, and then you start working at the site. I will tell you that there's a couple pitfalls when you remove the dressing, the old dressing, to get the site cleaned and prepped. Number one is that the tegaderms stick to anything that's plastic like crazy. And guess what the catheters are made out of? And guess what the little bio patch has a covering of? Plastic. And so they will stick to that literally like crazy. And so when you pull those off, you have to be really, really careful that you're not pulling out the catheter itself. That is when catheters get dislodged more often than any other time, is when they're doing dressing changes. And one of the things that I see people do on a regular basis is the little bio patch that they have. And there's a small slit that's in that. That slit, you want to pause for just a second and I'll go grab a, do we have a bio patch that I can show you guys?
I don't think so.
We do.
Is there not one in
Do we?
your?
Yeah,
That's
I
We'll,
saw it
we'll grab one,
yesterday.
we'll grab
Is
one.
there one in these kits? There's one in these kits.
Oh, there
isn't
is?
Can I
Oh,
just
open it
this
up.
kit?
I
Yeah.
gotta go do a huddle, I'm sorry.
Oh, sorry, okay.
That's okay, I'm like, I hate to leave.
You can watch the video. So the bio patch gets changed also.
Yeah. Yes, there's a bio patch in this kit. The bio patch has a small slit in it that a lot of people think is supposed to go underneath the catheter, and it's not. We're going to pretend that this is our catheter,
Mm-hmm.
and then I don't know if you can see this on the video, but there is a small slit that you can actually pull apart.
Mm-hmm.
That slit is not made so that it can go underneath the catheter like so.
Mm.
It's not the way that it's supposed to work. Because what happens is the tape sticks on both sides,
Mm-hmm.
and then when you try to pull that tegaderm off, you're going to pull that whole catheter out. So a bio patch, if you have the slit, just lay it down along the length of the catheter, and then just like that. That's all that you got to do. Okay.
Mm.
That way, when you pull the tegaderm off, it's just going to pull straight up, and it's not going to pull that catheter out.
Okay.
That makes sense.
Mm-hmm.
And I have to admit that I was guilty of that because I didn't know either before I started doing all this fun stuff and changing dressings. But these tegaderms, like I said, when you put them on, they will stick to that, and that bio patch, once it's stuck to the tegaderm, it's going to take the whole thing out unless you very gently kind of worry that away from the tegaderm itself. And sometimes you even have to cut it.
Mm-hmm.
But then once you have that off, then you just take your little chlorhexidine. Chlorhexidine just has a little ampoulettes inside, just like any other IV that you start. This is just a little bit larger volume. You just squeeze the two little things together and clean the area off nice and good. One of the nice things about chlorhexidine, and I don't know if you guys know about this, but it has a 24-hour active life.
Mm-hmm.
Not half-life, but active life. So that if I clean an area off with this chlorhexidine and I go back 12 hours later and touch it with my contaminated fingers, there's still chlorhexidine that's active at that site that's going to kill whatever bugs that I just brought there. So it's actually a really, really good deal to have underneath of your dressing. So chlorhexidine is really nice, but it's also one of the reasons why they don't recommend it at any place where you've got mucous membrane, so perineum, oral area, those kinds of things. They don't recommend using chlorhexidine around those areas. They still want betadine. But long story short, for what we do here at the arm, it's the perfect deal. I think your kit comes with a few other nice little things in here. It comes with sterile gloves. It comes with hand sanitizer, and usually those are the only things that you'll need. The catheter's held on to the patient with a something called a stat lock. It is a little piece of tape that's kind of stuck to the skin that has some plastic clamps that kind of
Like for a Foley, right?
Right. Same. In fact, it's made by the same company, but it has two little clamps that go on either side. Apologize. To catch onto the wings of the catheter itself. That stays in place, and that doesn't have to come off and on, because I don't think that your kit comes with stat locks in it. If that stat lock ever gets soiled or starts to come loose or anything like that, you can replace it. They come separate. And in PCU and ICU, I know they have them separately, so you may need to do those separate. If you have to change the stat lock, then you have to be really, really careful with the catheter, because now there's nothing holding that catheter in place once you take those clamps off. And so if you yank on it, you cannot put a catheter back in. Once it comes out of the skin, it has to stay. But here's the thing. Those catheters usually have about 4 to 8 centimeters worth of length that's going to be in the superior vena cava, all the way in the chest for PICC lines. And so there's plenty of play there for them to be able to come back a little bit. So if you pull them back 4 centimeters, it's not like you've ruined your IV or anything. The only thing that you'll have to do at that point is you'll have to secure the line where it's at, because like I said, you can't put that catheter back in. So you'll secure the line where it's at, and whether that's tape or whether that's a new stat lock, and you've got now, instead of 0 centimeters out, you now have 4 centimeters out and taped down. Try to keep that catheter in a straight line as best you can so it doesn't get kinked. But just secure it, and then get a chest X-ray just to verify that it hasn't flipped up into a carotid or crossed into a subclavian or something along those lines. But usually like I said, there's 4 to 8 centimeters worth of length that's inside the chest or inside the superior vena cava to be able to play a little bit with that.
Okay.
I think that's it as far as dressing changes go.
We've been so appreciative of your service, and you've always been so ready to come and help us. So that's been awesome.
No problem at all.
Because we are, we don't do them often enough to be super comfortable with it until we have one, and then
Right.
we get fine again. But
Well, here, like I said, I'm available Monday through Friday. Well, every other Monday I'm off, and every other Thursday I'm off. So, and it switches each week. But usually Monday through Friday I'm available. We used to have another gentleman here named Gerald, but he's gone to UT Southwestern. Rascal.
how dare he?
I know, right? But anyway, if I'm here, I will come and help you. I mean, call me if you have a question. Call me if you have a concern. I will come and take a look. I will help you out. I'll replace. I'll make suggestions. I'll do whatever else that I can do to help you guys out. I'm also pretty good at starting IVs. So I know you guys are probably better at starting IVs than most places in the hospital here, but
Some days.
I don't do sono-guided IV, so if you need a sono-guided IV, I'm not your person. I don't know why. I've tried. I'm not good at it.
Well, it's a different feel.
It is a different skill than doing a PICC, but I can usually start a regular IV before I can start a sono-guided IV. So if you ever need, if I can help you with that, I'm more than willing to help with that kind of stuff. Just give me a call. Like I said, Ken Day or Ken in Cath Lab. You can get a hold of me either way. If I don't answer, it's either because I'm home or it's a weekend and I'm just not on. So, but I promise I'll answer if I'm here.
Appreciate it.
All right.
Appreciate you coming.
What else can I tell you? The biggest thing is not to be scared of them. There's really anything to be scared of. Just a couple things to watch out for. Like I said, pulling that catheter out is kind of one of the worst things that you can do. But even that's not terrible. Aseptic technique, sterile technique as best you can, and you guys know how to do that kind of stuff. That's not anything new for you guys.
I know many of us get worried when we really have to put pressure on a syringe to get it to go, and that's where I was with that sheath
Yeah.
that I had. But you really can kind of push on them
Mhm.
to get that fluid in. And it's
So-
uncomfortable, but yes, I mean, not to the patient, to the nurse.
Yeah.
And,
So here's one of the things that I didn't mention about our PICC lines and midlines that we have here at this hospital. All of them are power injectable, which means that if you ever have a patient that has to go to CT and get contrast injected through their IV, all of these catheters are capable of that. That can take the high pressure. So I promise there's nothing that you can do with your thumb that's going to be higher than what those machines can do. One thing that I will tell you, or kind of, I don't know if you guys know this or not. I'm sure it's nursing 101, but just to kind of go over it again, is the smaller the syringe, the more pressure that you can put on it. So if you ever have a problem with pushing through, don't use a 10 cc or 5 cc, drop down to a 3 or even a 1 cc if you have them. That oftentimes will help you get things through to where they need to go. So it makes it a little easier on your thumb.
Good to know.
Suction is the exact opposite, by the way. The bigger the syringe, the more suction you make. So weird.
It's good to know.
All right,
Thanks so much.
you betcha. Thank you for
Of course.
this
Take some with you.